speaker, Dr. Ahmadi Fatima, Associate Professor in the Department of Anesthesia at Adi Chunchanagiri Institute of Medical Science. She'll be talking on MELD in our hands, anesthetic scoring systems for end-stage liver disease classification. We welcome you, ma'am.
Good afternoon, everyone. I'm Dr. Ahmadi Fatima from Adi Chunchanagiri Institute of Medical Sciences. This picture here, which shows an idea of a chilled life, is quite problematic. As you can see, there's obesity, the sedentary lifestyle, unhealthy eating habits, processed foods, which have all become important causes of fatty liver. So non-alcoholic fatty liver or non-alcoholic steatohepatitis has become the most common cause of end-stage liver disease, which is associated with high morbidity and mortality. But with the advancement in medical science, the life expectancy of patients of end-stage liver disease has improved significantly. So you will see these patients coming in for various emergency and elective surgeries. Despite all the improvements, the mortality still remains quite high in these patients. So these patients need careful assessment and prognostication. Now, several scoring systems have been proposed to predict mortality in these patients, which is the topic for today's session. The first was Child-Turgott-Pugh score, which was originally developed in 1964, was modified by Pugh in 1973, and this was used till 2000 to assess the severity of cirrhosis, prognosis, and also for organ allocation. This has 5 variables like albumin, bilirubin, prothrombin time, or INR, hepatic encephalopathy, and ascites, which are given a point ranging from 1 to 3 based on the severity. And these points are added together to classify them further into class A, B, C, which have predicted postoperative mortality of 10, 30 to 80% respectively. But this scoring had certain disadvantages where the hepatic encephalopathy and ascites were considered to be subjective in nature. So there could be observer variability and a difference in the scoring system. And also the arbitrary selection of cutoff values like bilirubin 2 to 3. So any bilirubin level more than 3 will also be getting the same 3 points. So these disadvantages were taken into consideration, and later there was a development of another model, that is the model for end-stage liver disease, which is the most commonly used model. Now in 2000, Malincock et al. Proposed the Mayo end-stage liver disease model to predict the prognosis of patients who were undergoing transjugular intrahepatic portosystemic procedures, that is TIPS procedures. It was later renamed as Model for End-Stage Liver Disease, and since 2002, it has replaced the previous Child-Turgott-Pugh score classification as the basis for liver allocation system in the United Network for Organ Sharing. Now, this is mainly based on objective variables, a little different from Child-Turgott-Pugh scoring. So this has bilirubin, prothrombin time, and serum creatinine levels. The original formula also had etiology, which was later removed since it was confirmed to be a less important variable. So this is the present formula. And the lower limit for all the variables was fixed at 1 so that we do not have a negative scoring. And the upper limit of serum creatinine was capped at 4. And the mortality rate, which was studied in patients with end-stage liver disease, as you can see here, with the increasing score, the mortality rate, 3 months mortality rate went on increasing. And it was also studied in patients undergoing surgery in end-stage liver disease. The 1 month and 3 month mortality is as follows. Now, MELD score was used for organ allocation, like we saw before, since 2002. And it is also used to predict the prognosis of patients with end-stage liver disease, also to predict postoperative mortality in these patients who are undergoing surgeries other than transplant surgeries. And it was also used in predicting long-term mortality in patients with chronic hepatitis or alcoholic hepatitis with or without cirrhosis. The main advantage was the objective variables, there's no observer bias, and also inclusion of creatinine. But the creatinine also became a limitation in this model because it can be easily influenced by other extrarenal factors such as muscle mass, sex, age, as we all know. And women or patients with reduced muscle mass, which is a case in most of the patients with end-stage liver disease, will show a lower MELD score. And the cutoff value was 4. So this means any patient who has a score more than 4 or who is on dialysis, not on dialysis, will also end up getting the same score. And this was considered less accurate in certain conditions like acute and chronic liver failure, hepatic cellular carcinoma, and other complications associated with liver cirrhosis because they themselves increase the mortality. So in these cases, there was something called a standard MELD exception score, which is used where they're given higher points because of higher mortality associated with these conditions. Now, the MELD score kept on improving over a period of time. There were a few additions and deletions. The next best score was MELD sodium. Now, sodium was considered as an important independent prognostic factor in these patients. So this was incorporated into MELD. And they found that it had better predictive ability compared to MELD score. So since 2016, UNOS has updated the MELD calculator to include sodium. And the sodium concentrations are given in milliequivalent per liter. Values anything less than 125 are set at 125. Anything greater than 137 are set at 137. But this also had the same limitations like MELD, where creatinine can be influenced, and also the capping. So this was the predictive mortality, 90 days mortality with MELD sodium score, which was better compared to the MELD. Next came the MELD-3, which was introduced by Kim in 2021. And this had additional sex and serum albumin into the formula, and additional points were provided to women. They also considered that there are correlation between serum albumin sodium, albumin creatinine, and bilirubin sodium. And the upper limit for creatinine was set at 3, so that the higher creatinine level, which can be due to some other intrinsic renal disease, will not interfere with the MELD score. The predictive ability was found to be slightly better with MELD-3. This is the formula. All these MELD calculators are available on the website of UNOS. And since 2022, MELD-3 has been used for liver allocation. In pediatrics, that is children less than 12 years of age, the pediatric end-stage liver disease score is used, where they have considered the unique characteristics such as growth and developmental aspects. So if the patient is less than 1 year old, they get an additional point of 0.436. And if the growth failure, which is defined as height or weight less than 2 standard deviation below the mean for their age, they get additional points of 0.0067. But the disadvantage was it tends to underestimate the 90-day mortality compared with MELD. Now, these scores were predominantly proposed over a period of time, also modified for organ transplantation allocation. And next we have Mayo postoperative surgical risk score. This was the first dedicated surgical risk prediction model which was validated in patients with cirrhosis. So this considered certain other factors other than MELD score, such as age, etiology of cirrhosis, and our ASA class, ASA physical status classes. So 3 was taken for compensated cirrhosis and 4 for decompensated cirrhosis. So addition of these factors definitely improved its predictive value and accuracy at detecting 1 and 3rd month mortality post-surgery in patients undergoing end-stage liver disease, which was found to be much better than the MELD scores. But the disadvantage was it was found to overestimate the predicted 1-year mortality rate after surgery, and it did not take into consideration certain factors such as portal hypertension or other complications, which can themselves be a major contributing factor to postoperative morbidity and mortality. And it does not provide any risk stratification based on the type of surgery. And we know that based on the type of surgery, the morbidity and mortality increases. Next, we have vocal pen score, which took into consideration the limitations of Mayo postoperative score. This is the veteran outcome and cost associated with liver disease and pen score, which is an updated surgical risk prediction module that accounts for the type of surgery. Now, this includes 9 variables, that is age, albumin, platelet count, bilirubin, and plus surgery category, what type of surgery, is it an open surgery, is it a laparoscopic surgery, it's a cardiovascular surgery, abdominal surgery, etc. And if it came as an elective or an emergency surgery, was also taken into consideration. They considered fatty liver disease, ASA classification, and obesity. So all these factors improved its predictive ability better than the previous scores. And also, along with non-hepatic surgeries, it was also validated as a predictor of postoperative mortality after liver resection in patients with and without cirrhosis. So to summarize, these were the scores from 1960s till date, which were modified over a period of time with addition and deletion of certain variables. This is a simple flow chart which will help us to determine whether to proceed with elective surgery in patients who come with liver disease. Now, in case of acute liver failure, it's better to defer, cancel, or consider alternative management. Yeah, provided it's an elective, if it's an emergency, we cannot help it, but we have to proceed with explained risk. If the MELD score is less than 10, you have to proceed with caution. If it's between 10 to 15, proceed with caution post-optimization. And more than 15, it's better to defer and consider other forms of management in lieu of surgery. So to conclude, these risk models are not a subject for clinical judgment. They can be used along with clinical judgment, and you don't have to use a single scoring system. You can adapt all the scoring systems and use it to help patient and providers in shared decision making. And if the predicted risk for an elective surgery is more than 15% at 90 days, it's recommended that these patients be considered for liver transplantation first and then go for surgery. I recommend you all go through this North PG et al.'s article on AGA clinical practice update on surgical risk assessment and perioperative management. It has given the best practice advices in patients with end-stage liver diseases. Thank you. Thank you so much for the opportunity. And I also take this platform to thank my HOD, Dr. Chetananand sir. He was supposed to come and present here, but due to his personal health, he could not come. I thank him for giving me this opportunity and constantly encouraging me and supporting. Thank you. Thank you so much.
Thank you, ma'am, for that insightful take on integrating liver scoring tools